Hi there, Dr. Dan Guerra from VerEvMed Studios. And what we're going to do today, as I think you probably have already decided and figured out because you're watching this, is we're going to do a VerEvMed lecture, a video lecture. And we're going to do it on a topic that I promised we would be looking at, and that is the use of prophylactic aspirin to improve human health. So there's a lot of history behind this, and we'll get into it as I go through the lecture. So I might as well just get started. Just recall, though, that I'm Dr. Dan Guerra, and I'm from VerEvMed, and VerEvMed is a company that you can access and determine whether or not you'd like to be our client. Basically, what we do is we go into the scientific literature and we examine the evidence that's there for a given topic for our client, and then direct that information to them via verification of all the other science that's available on that topic, and then provide them with a package that explains whatever their question might be. And this can be quite wide ranging, things from things like diet, interaction between pharmaceutical drugs, over the counter drugs, a whole series of other possible pharmacological, biomedical, and of course, foundationally biochemical, patho and regular normal physiological, genetic, epigenetic, cellular responses associated with whatever the topic is that a person might be interested in. So that's all I'm going to say about VerEvMed. Let's get started. All right. So first of all, here's a paper that came out of Clinical Pharmacist. You can see the citation there. And this is a background in aspirin. So if you want to know where aspirin came from, this paper really was quite dedicated to that question. According to the ancient literature, some 5,000 years ago, willow was considered a possible pain reliever. As we'll find out, aspirin can be obtained from willow, the willow tree. It also can be obtained from other plants. Jump way ahead to 400 BC during times of the Greek period, right around Socrates. In fact, Socrates died in 399, a dark year in history for sure. Hippocrates administered willow leaf tea to his patients. He was, of course, the Hippocratic Oath, kind of like one of the granddaddies of medicine. By 1763, jump again another 2,000 years, the Royal Society published the use of dried powdered willow bark for fever. Obviously, the active ingredient, because we're leading to this, was aspirin. Add another, 50, 60 years, Buchner isolated the active ingredient from willow and produced a bitter tasting substance that he named salicin. By 53, a French chemist named Guerra determined the chemical structure. And after you determine the chemical structure, you can, of course, see if you can chemically synthesize it. He did do that and published on it. And the structure of the compound is aceto or acetyl salicylic acid. We'll show you a structure in a moment. A little bit later, the first clinical trial of salicin or acetylsalicylic acid or aspirin was conducted, and it showed that it induced the remission of fever and joint inflammation of patients with rheumatism. That was published in Lancet in 1876. You can actually look at that paper. Go ahead a little bit more in the 19th century, 1897, Bayer, or Bayer Aspirin, Bayer Drug Company, a chemist named Felix Hoffman, realized that when that acetate group is attached, you get far more activity from the drug. And of course, we'll see why that is in a moment. So aspirin then, why it's called that, is A is for the acetyl. Spur is for the plant where they got the bulk of this drug, Spirea omaria, and it yields salicylic acid upon hydrolysis. So that's where you get the remaining part of the name. So that is aspirin. Okay, the IN is always used for suffixes of drugs. So that's it. Okay, let's go back a little bit and look at this paper from Van Bosis Research in 1980. This was one of the classic papers that first suggested that aspirin could be a good prophylactic for cardiovascular disease. So 1980, that's certainly not that long ago, 38 years ago, but this is when this whole idea started. Aspirin irreversibly acetylates the amino terminal serine of an active site of an enzyme called cyclooxygenase. That enzyme is in the prostaglandin and thromboxane biosynthetic pathways. Now, we talked about this in VerEvMed before. You can go back and look at those lectures when I did my lipid stuff. But we're going to go through it again, so don't worry. So when you take that drug, it causes a reduction in these compounds, which are cyclic endoperoxides of fatty acids. And you also knock down all the intermediates. So that means that this is probably one of the first reactions, which basically puts molecular oxygen into the double bond structure of these preformed fatty acids. In fact, it is the most common metabolic route for arachidonic acid, which is an omega-6 fatty acid, 20 carbons, 4 double bonds. And one of the common attributes of these products is the fact that they're involved in platelet function. And indeed, the products of cyclooxygenase, which again, the aspirin is going to be ending up inhibiting, initiate the aggregation or release of platelets. Okay? Aspirin further inhibits COX of other tissues, including the blood vessels, gastric mucosa, kidney. And such inhibition may corrupt defensive mechanisms operated by the prostaglandin, prostacyclin systems, resulting in fact in negative side effects of chronic aspirin use. So this was already in this 1980 paper, even though they're suggesting that aspirin could be useful potentially as a prophylactic, again, for cardiovascular disease, particularly second stage heart attack, okay, ischemic heart attack, infarction. That's where this first paper came out. All right, let's take a look at this pathway. We love pathways here at VerEvMed, of course. So you have phospholipids in the membrane, right? These phospholipids can be acted upon by an enzyme upon stress or injury, and the enzyme is phospholipase A2. Removes a fatty acid from the 2 position of preformed glycerol-containing phospholipids in the membrane. That fatty acid, often in the 2 position, is arachidonic acid. Again, it's an omega-6 fatty acid. It's the most common fatty acid in the 2 position of lipids like phosphatidylcholine and even in phosphatidylainositol. So arachidonic acid is released. It can be acted on by one of 2 enzymes, COX-1 or COX-2. They're both the same enzyme. They carry out the same reaction, but they work, they're modulated differently. And in fact, aspirin at low dose only inhibits COX-1. You need high dose aspirin to inhibit COX-2. There's reasons for that, which we might get into. The first product of that is called prostaglandin G2 or PGG2. And then the next reaction is still carried out by the same system, generates prostaglandin H2. And then prostaglandin H2 is the first central intermediate in the pathway. You can either go through thromboxane biosynthesis, and you can see what activates that are things like collagen, ADP, and thrombin. This is going to be all this blood clotting mechanism, okay, local. Or it can produce prostacyclin. Prostacyclin inhibits platelet aggregation, induces vasodilation, inhibits the proliferation of vascular smooth muscle cells. So therefore, it is anti-atherogenic. It also protects the gut, and it regulates renal blood flow. So this is actually a good, by the way, these are called prostaglandins because they were first isolated from the prostate gland, right? And they're also known as eicosanoids. Eicosa means 20, and eicosanoid, that means it has an oxygen in it, okay? So that's how this reaction will look when we finally examine it. Now, so when you inhibit this reaction, you see, you inhibit the synthesis not only of thromboxanes. Let's take a look at the thromboxane pathway. Most common one is thromboxane A2, TXA2. It actually induces platelet aggregation. It's a potent vasoconstrictor. It induces the proliferation of vascular smooth muscle cells, and it is therefore pro-atherogenic. So you see, these pathways work this way very frequently in biochemistry. In metabolism, you often have a bifurcation in a pathway after an initial reaction, where compounds are synthesized down one arm of the pathway, which will actually work against whatever the products are on the other arm of the pathway. This is a way of controlling a system that could otherwise get out of control and cause serious damage and health to the tissues and, of course, to the organism itself. So that's how this works with cyclooxygenase. Okay? So what's the mechanism of action? Well, here's aspirin. That's what it looks like. It's got this benzene ring. It's got acetate. There's the cyclooxygenase with the active serine. Salicylic acid loses, acetylsalicylic acid loses its acetate. Now you've acetylated that serine residue, and when you do that, you inactivate the cyclooxygenase. Now the same thing happens actually when you take acetaminophen, which is, acetaminophen also will disrupt the activity of cyclooxygenase. There's two domains in this enzyme, the peroxidase domain and the cyclooxygenase domain. Both of them are necessary to make PGG2H2. And you can see that even acetaminophen, which is not an NSAID, now I'll back up there, an NSAID is a non-steroidal anti-inflammatory drug. Indeed, acetaminophen is non-steroidal and it works against pain, but it does not work against inflammation. Aspirin does, as does ibuprofen. So ibuprofen and all of its congenitors, as well as aspirin, are actually NSAIDs. That's the classical term for that. I'm just showing you that this acetaminophen also corrupts this pathway. All right. So COX has two enzymatic activities. There are two COX isoforms, but each enzyme has two actual enzymatic events. There's the prostaglandin and the peroxide formation. That's PGHS1 and PGHS2. Isoform 1 reacts with fatty acids directly, while isoform 2 reacts equally with fatty acids or with 2-monoacylglycerol, okay, which is the lipase product of DAG. Okay, so that's a very important understanding. Okay, PGH has catalyzed two reactions. Okay, the cyclooxygenase, which is actually a bisoxygenase, which means it uses molecular oxygen, and it forms that PGG2, or if it's using the monoacylglycerol, it forms 2-PGG2 monoacylglycerol. Okay, so basically, what does that mean? So, when you've got lipase, okay, or when you've got a lipase making diacylglycerol, there's various kinds of lipases that will generate that. And then you remove one of the fatty acids, you'll have a monoacylglycerol. That fatty acid could still be arachidonate, it's an oxygen ester. So you can either make the 2-PGG2 monoacylglycerol, or you can make the PGG2, which is the free form of the icosanoid. Second reaction beside these cyclooxygenases are the peroxidases. They catalyze the 2-electron reduction of the 15-hydroperoxy form of PGG2 or of PGG2 MAG, it's monoacylglycerol. And then they're going to form then the PGH2 or the 2-PGH2 MAG. Okay, got that? Two different reactions, cyclooxygenase, which pumps O2 into the fatty acid, and then a peroxidase, which carries out a 2-electron reduction. This is the actual reaction mechanism, published in Feb's Letters, July of 1998. It looks like there's a tyrosyl radical that is involved in this reaction. And for each individual PGHS molecule, which is going to be activating here, you get feedback activation scheme. Okay, so check this out. You have latent or non-stress induced PGH synthase, which again is one of the reactions of cyclooxygenase. Carries out those initial reactions, making an active prostaglandin, an active PGH2. Okay, that will activate the enzyme. Okay, so the important point here is that that's an activating product, which will now activate the enzyme. And here's how the enzyme carries out that reaction. It's because the enzyme itself is a heme group, right? And it has to go through a different oxidation state for the enzyme to be fully on and functional. So in other words, the latent activity of the enzyme generates sufficient amount of the endoperoxide, which will then kick up the enzyme activity once there's high enough concentrations of substrate and, of course, molecular oxygen. When the reaction then proceeds, right, it's going to carry that arachidonic acid, it's going to oxygenate it. There's the active enzyme. It's going to oxygenate it, right? And it's going to generate a tyrosyl radical, which will ultimately then go through this reduction, and the enzyme will go back and recycle. So the peroxidases are steps 1 through 5, and the cyclooxygenases are steps 6 through 8. So let's go through this. So the enzyme symbols here, that's the big E, right, indicate the overall oxidation state of the enzyme heme, the peroxidase heme. It can either be in the 3 or the 5 state, or the 4 state, okay? So whether tyrosine 385, that's the tyrosyl radical in the enzyme, which is actually tyrosine 371 in the enzyme, is in the ground state, which is Y, or it carries a tyrosyl radical, which is Y dot. See, so it's right there. So you need to generate that radical to have the active enzyme. That's the point. That's the whole purpose of getting this endoperoxide, to generate that radical so that it's now biologically active and carries out the reaction. Isn't that sweet, right? Very interesting biochemistry. And of course, the ROH, and that's the hydroperoxide and the corresponding alcohol, of course, which are the products of the reaction. Compounds 1 and compounds 2 are the peroxidase compounds 1 and 2, and electrons are the reducing equivalent. Of course, AA is arachidonic acid right there. Okay, so that gives you the reaction. We could spend 15 minutes discussing this. There's more about it than what's shown here, but I just want you to get an idea of how the enzyme works. All right. Here I will give you the narrative. The initial step is the 13. Again, we're counting, okay, from the carboxy terminus of the fatty acid, the pro-S hydrogen removal from the arachidonic acid substrate. Remember, it's a 20-carbon fatty acid. The result is an isomerization, yielding a carbon-centered radical at the C11, allowing electrophilic attack of one of the atoms of molecular oxygen, generating that hydroperoxy radical, which again is the one that potently activates the enzyme. Again, happening at C11. You now add to that stable double bond at carbon 9. Okay, this leads to an intramolecular rearrangement and yielding a formation of a new carbon-centered radical at C15, moving ever further down that polyunsaturated fatty acid axis towards the methyl terminus. That's why you need all the double bonds. The double bonds then generate, right, the substrate for this reaction. Finally, C15 radical reacts with the second molecule of oxygen, producing a second hydroperoxy, now at C15, which goes through a 2-electron reduction to yield the alcohol. That's the peroxidase activity, and that's as I said there. The cyclooxygenase activity of COX then requires an initial hydroperoxy, which we just showed you, that must oxidize the heme prosthetic group to an oxoferryl heme radical cation located on that peroxidase moiety of the enzyme, right, at that site, at that locus. The oxidized heme then abstracts the electron from the tyrosine 385. That gives you the tyrosyl radical, that O dot, and that's the chemical moiety that starts the reaction via the removal of that pro-S13 hydrogen, okay? And that starts the reaction again. It's a very nice, straightforward oxygenation reaction. Now, the acetylation of serine of COX is what we want to talk about, and that is from aspirin. What does that do when you acetylate, when you add that acetate from acetylsalicylic acid, otherwise known as aspirin? It kills both PGH2s, but the hydroxyl is not an active serine, okay? The hydroxyl on the serine is not why it does that, okay? So there's a different reason for that. So it's an unusual aspect of COX. Normally when you see the hydroxyl group on serine and you acetylate it, you think that must kill the enzyme because the OH is involved in the reaction. Not the case. I just showed you it's the tyrosyl radical in the heme prosthetic group. Serine wasn't there involved, was it? Not at all. So what's going on here? The acetylated serine prevents the required close proximity of the enzyme itself, the molten enzyme, to its substrate. So the enzyme is dead. Right? So when you acetylate that serine, that repositions the enzyme in the membrane so it cannot get to its substrate. That's why it kills it. Amazing stuff, right? So steroids work at a different level. They actually prevent the transcription of the PGH2 isoform. Okay, so that's really what steroids do. Steroids don't inhibit the enzyme. They inhibit transcription of only one isoform of the enzyme, PGH2. Now you know. All right. Again, this is from the thrombosis research paper of 1980, low-dose aspirin inhibition of thromboxane B2. Remember, thromboxane is the bad prostaglandin, bad in the sense that it causes platelet aggregation, not bad in terms of normal physiology. So you got here's aspirin, ASA, acetylsalicylic acid, 200 milligram. Here's a time course, right? Up to, 60 minutes. Here's the control activity at 37 degrees. When you add low dose, 200 milligrams aspirin, no activity. And you can see that it's temperature dependent, right? You can see at lower temperatures, you get no activity of the enzyme. That shows you it's an enzymatically catalyzed reaction, by the way. So if you're inhibiting the enzyme, okay, you're inhibiting the production of thromboxane A2, how much is in the serum? So does this actually translate to reducing the amount of this pro-aggregating icosanoid known as thromboxane A2, or this one's B2 here, just a different isoform of the same compound. And yeah, so hours after aspirin, you really knock down the serum concentrations of thromboxane. So wow, if you can reduce the amount of thromboxane, and that causes platelet aggregation, that platelet aggregation is involved in cardiovascular disease, primarily something like a heart attack, right? Then it's possible that aspirin could be used as a prophylactic to prevent a second heart attack once you have patients that are prone to heart attacks. That was the whole idea way back in 1980. All right, just showing you again the effects of an oral dose of aspirin given to a healthy man every 72 hours on thromboxane B2 formation during whole blood clotting. Right? Arrows indicate time of day when it was administered. And you can see well into 2 months of time that serum thromboxane level is down. So if you keep on taking aspirin, see, this was the initial paper that said, take aspirin, reduce thromboxane, reduce that aggregation of platelets, reduce the possibility, the potential of another heart attack. And it shows you can keep that thromboxane B2 down. Now, you might be asking already, well, wait a minute. What does thromboxane B2 normally do? Well, I just told you, right? It's involved in aggregation of platelets. Now, is that important? Of course it is. That's part of the blood clotting mechanism. So what do you think happens when you take chronic levels of aspirin? You can get bleeding problems. It's not the only thing that happens. So right away, you can see that there's a potential danger of taking this very potent drug prophylactically and chronically. All right, now let's get a little bit more into this. This is kind of fun. So selective COX-2 inhibition and enhanced cardiovascular risk. Let's take a look at this. So there you've got platelets. And then we're looking at thromboxane A2, okay, still the thromboxane. And we're looking at the level of prostacyclin, okay? So nice dilated vessel wall, normal platelets, right? Arachidonic acid is going to produce equivalent amounts of thromboxanes and prostacyclins, okay? So you're going to have the thromboxanes generated at the platelets, that's the COX-1 enzyme, and the same substrate, arachidonic acid, is going to make prostacyclins in the endothelia of the vessel, right? And that's going to make prostacyclin, which is going to do what? Vasodilate. So it's going to allow blood clotting, but it's going to maintain dilation of the blood vessel. Now, when you get a constricted vessel, what's going on is you get lots of thromboxane generated, you see? So that gives you the clumped platelets. So here, if you get a COX-2 inhibitor and only inhibit COX-2, see that, the endothelial form, what you do is you don't get any protection from the prostacyclins. No protection from the prostacyclins. What do you get? A boatload of thromboxane A2 because it shifts in that direction. And that means you can then enhance cardiovascular risk. That's why COX-2 inhibitors were pulled off the market because it was killing people. Okay, and why were they going after COX-2? Because they figured if you went after COX-2, maybe you could prevent the production of thromboxane in the endothelia, where most of that isoform is. It was a bad idea. It was a bad pharmaceutical industry decision, and it killed people, and that's why they pulled the COX-2 inhibitors. All right. Now, we also have to establish that there's a link, and we've already been hinting and alluding to it, between cardiovascular disease and thromboxanes. Coronary heart disease, otherwise can be called CHD, accounts for about 10 to 20% of total mortality worldwide. So it's quite one of the major killers. There are 6 things that kill people, and that's one of the major ones. Right? Cancer, of course, is another one. I won't go through the list. The prevention of cardiovascular disease or coronary heart disease involves emphasis on lifestyle, including a lower BMI, avoidance of sodium chloride or reduction of it in the diet, regular exercise, that means every day. And since the 1980s, we've known this and we've suggested these lifestyle changes to prevent, especially, a second myocardial infarction event. Now, also since the 1980s, it's been suggested to use prophylactic aspirin. Usually it's at 80 or 88 milligram of aspirin, which is, again, low dose, 1 pill per day. Aspirin inhibits platelet aggregation, blood coagulation, and, of course, thrombosis. We just showed you that. Long-term aspirin use can increase, however, the risk of gastric mucosa injury, bleeding, hemolysis, hematopoietic dysfunction, and cancer. Those are the side effects. Quite terrible stuff, right? So it's been known for a long time this can happen, but there's been considered a good trade-off. Prophylactic use of aspirin has therefore come into question, though, because why don't we take a step back and do a meta-analysis and find out, or let's do a new study even, find out what is aspirin doing to the human population. Millions of people are taking this every day. Was this the right decision? Now, some of us, lipid biochemists, teaching lipid biochemistry in graduate schools in various parts of the country, someone like me, were saying back in the early 90s, even in the late 80s, that, whoa, wait a minute. If we are going to be inhibiting thromboxane synthesis, we're also inhibiting prostacyclin synthesis, which means we could still cause a problem with heart attack, as you saw when they went with the COX-2 inhibitor. Bad idea. But not only that, there's a lot of chemotaxis involved in the production of eicosanoids. Chemotaxis of what? Immune cells. If you inhibit initial immune responses, inhibit chemotaxis of things like blood leukocytes, particularly even some lymphocytes like T cells, you could actually also decrease the availability of those immune cells to target injury to the system and to target virally infected cells, which is part of the immune system, of course. And what else? Tumors. So that's how cancer can possibly be impacted negatively, which means cancer risk could increase by taking a compound that inhibits eicosanoid production. That's what NSAIDs do. Okay? Kill pain, lower inflammation, but at the same time, that inflammation is necessary to kill things like tumors and virally infected and bacterial infections, etc. All right. So here's the effects of NSAIDs on platelets and endothelium. There's your platelet, either a platelet or the endothelial cell. The endothelial cell has both isoforms. Right? You're going to be making the prostacyclin, which is going to cause vasodilation. Right? That's going to inhibit platelet aggregation. So we already showed you this. Whoops, sorry. There we go. And also thromboxane A2, that's only the COX-1 and platelet that you really want to be targeting. So non-specific NSAIDs like salicylic acid, right? It's going to cause, when you make thromboxanes, you get vasoconstriction, promotes platelet aggregation, you can get hemostasis and thrombosis, okay? So this was the whole idea, get rid of that pathway, right? Okay, just reminding you. So we're going to take a look at 3 papers that were just published, all in the New England Journal of Medicine. That's why I'm giving this talk. All right. Now, before we do that, let's step back a second and ask ourselves about aging, something I've talked quite a bit about in VerEvMed. Here are some molecular hallmarks of cardiovascular aging: cellular senescence, genomic instability, chromatin remodeling, and mitochondrial oxidative stress. All things I spent a lot of time talking about at many VerEvMed lecture loci. So what happens when you get mitochondrial oxidative stress is you can get programmed cell death. You can also get inflammation. When you get mitochondrial stress, which happens with aging, you get cardiovascular aging. Okay. You can also have endothelial, smooth muscle cell senescence by aging. Okay. And this is linked to cell divisions, which is involved in the aging process, which includes telomere shortening, which involves an increase in apoptosis and an increase in thrombosis. That's why when you get older, you're more prone to cardiovascular disease. Okay. It also decreases adrenergic signaling, which is actually prophylactic against atherogenesis, and calcium homeostasis also decreases with age. So these are cardiovascular risk factors. Okay, so that's important to know. Likewise, genomic instability. You can have endogenous, which is just oxidative stress and alkylation. Again, I talked about this. Talked about this in various VerEvMed lectures. You can go back and look at those. And then exogenous genomic instability caused by radiation. For example, like radiation involved to knock out tumors. Chemicals can cause genomic instability, as can pollutants. So chemicals, just chemicals in the diet or the pharmaceuticals. DNA damage itself can decrease the amount of eNOS, can decrease the amount of sirtuin metabolism, which is a deacetylase, and increase the amount of NADPH. All of that can lead to endothelial dysfunction. So genomic instability, mitochondrial oxidative stress, and endothelial smooth muscle cell senescence, all associated with aging, will link to a pathology known as cardiovascular aging. You also get epigenetic changes that occur over time, and these can be caused by various chronic endo and exo-mediated responses, again, that I talked about over many rewarding VerEvMed lectures. So what does that mean? You decrease the amount of methylation, so you get less methylated sites, and you also alter the histone code, and that enhances acetylation, which can then give you changes in gene expression, and in this case, altered expression of oxygen inflammatory genes, and that can lead to further vascular dysfunction. So understand that's why aging population, why you get cardiovascular disease. Right? Genetic predisposition notwithstanding, all of these conditions will also lead to it as you age. So, first paper in the New England Journal, the effects of aspirin on cardiovascular events and bleeding in the healthy elderly. Okay, again, just published September. Cardiovascular diseases are the principal cause of disability and death as people age. Okay, low-dose aspirin is among the most widely used agent to prevent cardiovascular disease. And the AMA and some of the published research on the subject claimed from largely epidemiological secondary prevention trials extolling the reduced myocardial infarction and ischemic stroke, even though the risk of internal bleeding and hemorrhage were at the beginning noted as concerns. That 1980 paper talked about it. I showed you that. For primary prevention of cardiovascular disease, the data is far less compelling for aspirin drugging of the healthy. So a lot of people take aspirin prophylactically. They never had a heart attack, never had a stroke, start taking it in their 50s. Men primarily were the ones that were recommended, because men, about 2 or 3 to 1, actually are ones that get first heart attacks. Women are much less likely to get heart attacks. So men have been taking aspirin ever since the 1980s, prophylactically, low dose. Remember what it's doing to the cyclooxygenase. But most of the data really talks about having a secondary ischemic event, either stroke or heart attack, being prevented potentially by aspirin. Not for healthy people that never had the condition, because not everybody will get it, right? So the potential of cardiovascular disease is higher in the aging population. I just showed you that. So perhaps the benefit of aspirin may be more compelling than with the younger segment of the population. Younger meaning people like even my age, okay? So you don't have to be quite elderly for people to suggest you taking aspirin. People in their 50s and 60s are often told by their physicians, well, you might want to take a prophylactic aspirin because research shows that prophylactic aspirin can decrease your potential for cardiovascular disease or stroke. So those are relatively young people when you look at an aging population and the substructures of how these diseases impact that aging population. For example, 65 is a totally different kettle of fish than 70, then 75, then 80, then 85, etc. in terms of programmed increasing risk of cardiovascular disease or stroke. So what do I say? However, an increased bleeding in the elderly is well documented, so the risk benefits need to be addressed. All right. So the method they used in this paper, dates of the trial went from 2010 to 2014. Men and women, both in Australia and the United States, who were healthy, 70 years of age or older, and who were free from previous cardiovascular disease, dementia, or disability. Okay, so they looked at they looked at multiple races. They looked at white. They looked at African American, and they also looked at Aboriginals in Australia. All right. So the participants were randomly assigned 100 milligram, that's low dose aspirin, of an enterically coated aspirin, or of course placebo, which was just nothing. Primary endpoint for this study was death, dementia, or persistent physical disability. Okay, how does it affect any of those major endpoints, right? Secondary endpoints now, more specific. Major hemorrhage and cardiovascular disease defined in fatal coronary heart disease, non-fatal myocardial infarction, like a first heart attack, fatal or non-fatal stroke, or hospitalization because of heart failure. Okay, so secondary endpoints were quite serious. So what they did is they calculated events per patient year. And that's the number of incident cases divided by the amount of person time at risk. Now, why do they do these sort of weird person or patient years? It's because it's a formulaic method that works well for statistical analysis of data like this. That's why it's done. So the calculation could be accomplished by adding the number of patients in the group and multiplying the number of times the years that the patients are in the study in order to calculate the patient years, okay, which is going to be in the denominator. That's how it's done. Then divide the number of events. Higher the number, the more severe the outcome. Okay, basically, that's what that means. So it's really easy to read that out. For example, if you have 100 patients followed for 2 years, in this case, there are 200 patient years of follow-up. See how that works? If there were 8 myocardial infarctions in the group, the rate would be 8 myocardial infarctions per 200 patient years, or 4 MIs per 100 patient years. Got it? The rate can be expressed in various ways, so per 100, per 1,000, per 1 million if you want, depending on the aggregate size of the population you're trying to analyze. That's one thing then, patient years. The other component data you're going to look at is hazard ratio, and we talked about this many times before, but bringing it up in case you haven't watched one of my previous VerEvMeds or because you're a little rusty on this maybe. Hazard ratio is a comparison between the probability of events in a treatment group compared to the probability of events in the control group. Probabilities, okay? Choose to see if patients receive a treatment progress faster or slower than those not receiving a treatment, progressing then to some endpoint like mortality. So a hazard ratio of 3, for example, these are examples, means that 3 times the number of events are seen in the treatment group at any point in time. So if it's a negative endpoint, you don't want a hazard ratio of 3. Very bad, right? In other words, the treatment will cause the patient to progress 3 times as fast as patients in the control group. Any ratio above 1 generally means the treatment group healed faster. So if it's a drug that's in healing, or if your endpoint is something like looking at a positive outcome, and that means it has slower time to an event, okay, such as, let's say, the first cardiovascular event. A hazard ratio of 1 means that both groups, treatment and control, are about equal. Okay? Hazard ratio of, say, down to 0.33 now, okay, less than unity, tells you that the hazard rate in the treatment group is 1/3 that of the control group. Okay, so you got that? All right. Now, here's our data. Cardiovascular disease, take a look at this. Overall, number of participants with event, number of participants with aspirin, there's your rate per 1,000 person years. There's your hazard ratios. Right away, what are you seeing? 0.95, 0.89, just look over here. 0.97, 1.07, blah, blah. So right out of the paper, I'm quoting, no evidence of a differential effect on aspirin on the risk hazard ratio of cardiovascular disease in any analysis of the prescribed subgroups or in post hoc analysis of the subgroups of potential relevance to the risk of CVD. In other words, taking aspirin for those 4.5 years did not help with any of the primary outcomes, which were all negative, right? Like mortality, overall disease risk, ischemic heart attack, etc. And that's compared to the placebo. Okay, you can see here cardiovascular disease, fatal cardiovascular disease, hospitalization for heart failure. Okay, when these numbers are all sitting right around 1, that means there's no difference between the placebo or the aspirin. Here, just graphically representing, there's a cumulative incidence, right? Years since randomization. You're just taking a look here, placebo versus aspirin. Basically, there's no difference. Okay? It's just showing you number at risk. where they generated this graph from. That's at the 95% interval. So basically nothing positive. Okay, third bit of data from this. Okay, now we're taking a look at the negative effects. Intracranial bleeding, major hemorrhage. Look at here, hazard ratios, taking aspirin versus taking placebo. And this is at a p-value of 0.001. Oh my gosh, hazard ratio of 1.38, okay? So that means that if you take aspirin, you're more likely to get major hemorrhage at 38% more likely. Got it? So breaking it down into different kinds of bleeding, intracranial, any kind, pretty high hazard ratio, 1.5, hemorrhagic stroke, 1.27, subdural extradural hemorrhage, 1.79, subarachnoid hemorrhage down to 1.3, extracranial bleeding like GI, almost 1.9, upper and lower segregated out there. And then, of course, fatal bleeding like major hemorrhage. Now you don't see any effects, okay? So it didn't kill the people, but it predisposed them to a whole series of major hemorrhagic events taking aspirin. So that is not a good thing, particularly if you look at, say, upper GI bleeding, right? Upper GI bleeding, wow, that's almost twice as bad taking the aspirin. Definitely a very negative outcome. Definitely not a good indicator for taking prophylactic aspirin. And that shows it here in the graph, right? As you go out in years, right, aspirin consistently caused higher levels of hazard throughout all the years of study as compared to placebo. You would want that on the other side of the placebo, or at least, if nothing happened, and we're right on top of each other, but it's worse with aspirin. Quoting again from the paper exactly, the progressive increase in the cumulative incidence of major hemorrhage across the trial follow-up period indicates that the risk of bleeding persisted throughout the course of therapy. This is not a good indicator. All right, let's summarize for his paper. Low-dose aspirin offered no significant benefit on cardiovascular disease. We saw that. Hazard ratios all clicking around 1. Patient ear, same thing. Did not present with higher risk of bleeding. Okay. The incidence of bleeding in the elderly is substantially higher than the incidence in younger people. The trial enrolled healthy elderly from the general population, so it might be broadly applicable to the healthy elderly in general. Since the healthy elderly are the group that are most likely to obtain cardiovascular disease at age, low-dose aspirin does not seem to benefit the patient target population. So remember, statistically, some of that bleeding didn't come out, right? But some did. So that's why they're trying to say, well, maybe it's not real bad, but it certainly shows no indication of improving health, according to these endpoints and parameters. Second paper, effective aspirin disability-free survival, again in the healthy elderly. There's New England Journal. By the way, all 3 of these papers are open access. You can get to them and read them yourself. Very straightforward. You don't need a PhD or a medical degree to read them. Aspirin and Reducing Events in the Elderly was the name of the trial funded by your NIH called Aspirin. And it was a randomized, placebo-controlled study to determine if low dose, again, 100 milligram aspirin in the healthy elderly prolongs a dementia-free, disability-free healthy lifespan. That's what the outcome when they were looking at. Primary endpoints then were death, dementia, and persistent physical disability. Okay. Endpoints. The Aspirin trial had 8 pre-specified secondary endpoints, including things like these 3 individual in the primary endpoints, such as death from any cause, dementia, persistent physical disability. The secondary endpoints then included fatal and non-fatal cardiovascular disease, including stroke, fatal and non-fatal cancer, mild cognitive impairment, depression, psychiatric measurement, and, of course, major hemorrhage. Take a look at the data, graph. What do we get? Okay, there are your p-values. That's a really ugly p-value there. Look at the hazard ratios, 1, 1.14, 0.9, 0.85, 1.38. They didn't generate hazard ratios for these because these numbers just did not look like they were giving you any changes here. So basically, your hazard ratio throughout this study, for all the endpoints we just talked about, shows you that there's nothing really associated, beneficial from the aspirin. So cumulative incidence of primary composite endpoints, which is looking for a healthy endpoint, aspirin and placebo were right on top of one another, as shown by the hazard ratios being on top of one another. So there was no plenary and plenum positive effect of taking aspirin in the healthy elderly with looking at these endpoints. Okay, here's all deaths. Aspirin shows maybe a little bit higher there, but not statistically significant, maybe at a very high level. There is dementia. Doesn't look like aspirin's causing anything problem there. And here, persistent physical disability. Placebo looks like it's a little bit better than aspirin. But again, meaning that aspirin might have a positive effect, but it's not statistically significant. That's just showing you how the data broke down. Let's summarize this data. Daily 100 milligram aspirin did not differ significantly from placebo in influencing the rates of disability-free survival for a 4.7-year study. No significant, remember these are people over 70. Significant difference was identified regarding the effect of aspirin between participants in the US and Australia. So that gives you two different cohorts, right? And across a range of other subgroups. It includes male, female, different races, etc., like I talked about at the beginning. By reducing platelet aggregation and thrombosis and the risk of ischemia in the heart, brain, and other organs, aspirin was expected to reduce the incidence of disability from various causes. They didn't achieve that endpoint. An increased risk of bleeding due to aspirin might cause intracerebral and GI bleeding. We already saw that. When all the events, not just the first event to occur, were taken into account, the rates of dementia were similar in the two groups, and there was no evidence of an effect of aspirin on the rate of persistent physical disability. The differences in the rates of death from any cause between the two groups could be a chance finding. Okay, so there's not enough information to say that anything beneficial came, and so it doesn't look, once again, second study, this Aspirin study, no positive benefit from taking prophylactic aspirin in the unhealthy elderly. So use of low-dose aspirin in persons 70 years of age or older who did not have cardiovascular disease did not prolong disability-free survival in a predominantly white population, with an indication that the same could be for other groups, including Hispanic and Black. Now, the reason that caveat's in there is because it's a different age structure for getting cardiovascular events, with the African American population starting a little bit earlier at 65. So there were less people in this overall research plan. So we could go back and do this again, now just emphasizing African American, now just emphasizing Hispanic, now just emphasizing Asian. Asian tend to not have anywhere near the frequency as those other three groups do. But overall, the trend is aspirin has no positive effect in these massive studies. Third paper, effect of aspirin on all-cause mortality in healthy elderly. It's the third one. Aspirin in reducing events in the elderly. Again, the Aspirin trial was primary prevention trial with daily use of 100 milligram. Primary endpoint was disability-free survival, which was defined as survival free from dementia or physical disability, examining all sources of death, dementia, persistent physical disability. Overall was higher. Overall mortality was higher in the aspirin group than the placebo group, but it wasn't significant. And here the trial focused on specific causes of death. Okay. Here are the methods and endpoints. They did phone contacts quarterly and face-to-face annually. If the patient didn't respond or show up, review was conducted, including contact with the next of kin. Distinction of death required confirmation from two independent sources. That's good. Cause of death included health records and death certificate. That's also good. Besides establishing cause of death, the proximal cause was determined. For example, let's say you say they died of cardiovascular disease. What did they die of? Heart attack, hemorrhage, organ failure, etc. And they did classical Cox. That's not the cyclooxygenase enzyme. The classical Cox proportional hazards model was used for the study. Now, what is that? And again, this is Cox. This is the way the statistics work. This isn't the enzyme. Sorry for the confusion. Cox is a popular regression technique for survival. So again, I like to look at the techniques and methods they use to make sure that I feel like they're valid. It relates, sorry, misspelling there, several risk factors or exposures are considered simultaneously to survival time. The measure of effect is the hazard rate, which is the risk of failure, that is the risk or probability of suffering the event of interest, given that the participant has survived up to a specific time. Probability has to lie within a range of 0 to 1. The hazard represents the expected number of events per 1 unit of time, so the hazard in a group can exceed 1, of course. Example, the hazard is 0.2 at time t, time units are months, then on average, 0.2 events are expected per person at risk per month. That's why they break it down this way. Another interpretation is based on the reciprocal of the hazard. For example, 1 over 0.2, which is 5. That gives you now a whole number, which is the expected event-free time, for example, 5 months per person at risk. So that's Cox. You can play around a lot with what you get out for readout. So take a look at the data. Cause of death: any cancer, cardiovascular disease, including stroke, major hemorrhage, any other. What do we got? The only disease that gives you any real change in the hazard ratio is cancer. And in fact, aspirin increases by 31% the possibility of cancer, according to this study. Okay? That's compared to any cause of death, which is not statistically different. Cardiovascular disease, which does show that, again, that little bit of a decline. Okay, it's an 18% decline taking aspirin because it's not 1. There's your beneficial possible effect of aspirin. It's not statistical. Major hemorrhage, of course, a little bit higher with aspirin, but again, not significant. And any other cause of death also not relevant. Okay. So once again, here's death related to cancer. Here's the one that was really kind of spooky from this study. Yeah, it looks like at the 95% confidence interval, hazard ratio for aspirin over time increases. The rate increases. That means that prophylactic use of aspirin in the healthy elderly could, over time, increase the potential and therefore the hazard of contracting cancer that would lead to death, okay? Because of the effects of altering the eicosanoas because you're inhibiting the cyclooxygenase. Okay? Here's all the cancers. Okay? There's the 0.31, and it's broken down. There's a really bad one there, colorectal cancer. Not surprising because it causes a lot of bleeding in the GI tract. Almost, 77% higher taking aspirin. Pancreatic, 40% higher. Here's a really bad one, breast cancer. Double the hazard ratio by taking aspirin. Again, this is male and female. 1.46 for melanoma, another bad one. There's melanoma. Brain cancer, 1.46. So these are the real bad ones. So you break down the different cancers. See, anything that causes hemorrhaging in the brain can lead to these cancers. And obviously, this kind of downplay of the inflammatory response can lead to cancer, and some of the major causes of death are breast cancer, for example, and melanoma, and of course very deadly is brain. That's why this was linked into the death incidence. And you can see this is really not good statistics. Health hazard very high by taking aspirin for these cancers, and overall not good anyway, any kind of cancer. Isn't it? The only, I guess, positive thing you could say is lung cancer, leading cause of death. Aspirin didn't seem to have any real effect. And it's just showing you better where aspirin's better according to whatever different sex. Okay, we don't see it's better here. Country, aspirin looked like it performed a little bit better, but look at that huge standard error. In Australia, now in the US versus Australia, is that right? Yeah, okay. Where aspirin might be better are in, let's see, here's the US again, broken down with race, with whites in the US, with blacks in the US, and maybe with Hispanics. But look at the standard error, right? Any other, like with Asian race, it's actually not improved. And then here are all the different diseases with aspirin. Not improved. Placebo was better for diabetes, hypertension. Skip the smoking for now because that just adds to frailty. You don't really see any good changes here. Personal history of cancer. Sorry, let's go back to this. And all those the ends of those results again showing you body mass index, etc. So aspirin certainly does not outperform in any general way with any of these overall conditions. So what are the overall conclusions? Within a healthy adult population for people over 70, with no reason to take an NSAID like aspirin, all-cause mortality was apparently higher among those who received daily low-dose aspirin. That is not the result you want. The data revealed that there were 1.6 excess deaths per 1,000 person years in aspirin group, with risks increasing as the trial continued toward almost 5 years. Other primary prevention trials of aspirin have not identified these results. So these are brand new results, just out late September. So today's October 1st, just a few days ago, basically, in the New England Journal of Medicine. You can take a look at these papers, go back and look at them up. They're all open access. So I'm presenting this to show you that now I'm pretty sure you're going to see the AMA come out, eventually get filtered down into clinics and physicians' offices, that maybe it's not going to be recommended to take prophylactic aspirin at low dose for healthy elderly. Not probably going to be recommended based on these trials. Now, again, like anything else, you need to take a look at this in terms of the other entire data. A lot of other data has shown that taking aspirin does improve health because of the cardiovascular risk being decreased. So let me do this diaventometry of these trials. And let's see what's wrong with these trials. No measure of COX-1 or COX-2 drawn from blood leukocytes. They could have measured the amount of protein, the amount of activity. There's no genetic or epigenetic patterning amongst these groups for COX. The enzyme PLA2, which initiates the whole system because it generates the free arachidonic acid, or 2-MAG. Eicosanoid receptors were not analyzed, or membrane protein assemblages for those receptors were not looked at. They could have been. They could have isolated all the different times they brought people in. For some of these studies, they could have drawn some blood and they could have gotten this data. Of course, there were no immuno or neurobiochemical or cellular markers obtained, right? This is just looking at, again, epidemiological factors, all-cause mortality, cause of death, things like that. Compelling evidence that cannot be purposefully verified according to pharmacological target or biochemical pathophysiological endophenotypes. Okay, so it's compelling, but it cannot be verified. I can't verify it for you because I didn't see all of this really much required biochemical data and cellular data and pathophysiological data. It doesn't mean that the data is wrong. It just means that we didn't get a complete diabetological aspect of it. We don't look at how the immune system, genetics, and epigenetics work through time to alter the immune system to regulate the effect of aspirin on a healthy or non-healthy system. That's what I mean by a diabetological aspect. So I say follow for specificity and reproduction of the results is definitely wise. Till then, taking prophylactic aspirin may be simply caveat emptor, buyer beware. I can tell you that I personally have never thought that this was a good idea for the reasons I suggested, because inhibiting something like the cyclooxygenase enzyme knocks out all the prostacyclin metabolism, also knocks out all of prostaglandin metabolism, which does more than just control platelet aggregation and immune system. It does a whole lot more than that. So I would never have taken it anyway. And I think you can walk away from this and you can make your own decisions. But based on these data, you might want to hold off on taking that one aspirin pill a day. Again, it's just what the papers look like to me, although I did give you a lot of caveats about why we need to really study the biochemistry and cell biology and pathophysiology of this to look at this in more detail. Thanks a lot for your attention. Hopefully that was something that was valuable to you to learn about aspirin, a little bit about the mode of action of how it works, what enzyme it knocks out, why it is a potent drug, very potent drug, even though it's over the counter. And these new data recommending, to me at least, that take another look at whether or not prophylactic aspirin use in a general, healthy, particularly elderly or aging population is such a good idea after all. That's me, Dr. Dan Guerra. There's my individual email address. Contact me, and within 24 hours, I will likely be able to get back with you. We'd very much like to have you be a client at VerEvMed. There's our website. Please go visit it. And all I can say is at the close of all of my talks is my normal sign-off, and that is to say, let me get this here. Bye for now.